Hi, everyone, and welcome to this edition of the Taking Control of Your Diabetes podcast. I am one of your hosts, Dr. Jeremy Pettus, joined as always by my good friend and colleague,
Steve Edelman.
So if you're just tuning in, we are both endocrinologists at the University of California, San Diego. We both do research and see patients in diabetes and also work for the not-for-profit organization TCOID, which Steve founded about 30 years ago. So thank you for joining us. Today's podcast is on what we're calling the musculoskeletal issues for people with diabetes. And what is musculoskeletal? Well, it kind of means those two things, muscular and skeletal, things that affect your muscles, your joints, and broadly speaking, things that might cause kind of aches and pains. So, as we always like to say, why are we talking about this topic? Well, it's incredibly common in people with diabetes. And when people with diabetes talk about, man, I want to control my blood sugars to avoid long-term complications of diabetes, what they're usually thinking about is their eyes, their kidneys, maybe the nerves in their feet. These things that are kind of beaten into us since we were diagnosed of those are the complications of diabetes. But guess what? There's other complications. And Steve, we always talk about, man, add it to the list.
Yeah.
But most people with diabetes, over 80%, will experience some kind of aches and pains in their life that are due to diabetes. So we're going to focus the majority of this podcast on things that are actually ultra specific to people with diabetes that don't really occur in people without diabetes. But that being said, we wanted to say that off the top, these kind of common things can be actually more common in people with diabetes. So what's the most common thing that causes people aches and pains? It's low back pain. And Steve, is low back pain more common in people with diabetes?
Absolutely.
Yeah. So that's not caused by diabetes, but people with diabetes can tend to be heavier. They might not have as much kind of muscle strength or things that might kind of predispose them to low back pain, but it's not kind of diabetes specific. Other things like plantar fasciitis, man, I've dealt with that through my life and I hate it. What a pain to wake up and have pain in your feet and have to do inserts and all those kinds of things. So if you're listening and you're thinking, gosh, I'm struggling with low back pain or plantar fasciitis or whatever it is, we feel for you. And the, treatment is going to be physical therapy and a lot of time and effort to fix that. But we want to focus on some things that I'm pretty positive you have no idea are related to diabetes and they might be affecting you. So Steve, do you want to give an intro?
Yeah, well, that was a great opening, Jeremy. And we did do a TCOID live on this with a rheumatologist who's an excellent physician. And afterwards, your comments reminded me to say that we got probably over 100 questions and comments like, I had this, I had that. And people were they didn't even know that it was under this category of musculoskeletal issues of diabetes. And you're right. It occurs in the majority of people from a wide spectrum of a little stiffness in your hands and maybe your back to full-blown frozen shoulder, syndrome of limited joint mobility, trigger finger, some of the issues we're going to talk about.
Yeah. And we're going to go through these literally one by one, hands, shoulder, all those things. And, I did say on that live that we did, Steve, that I remember years ago, probably a decade ago, I asked you, what is the number one thing that's bothered you about diabetes? And I was kind of surprised at the time that you said it's these issues, that pain that you've had or trigger finger or your frozen shoulder or things like that. And you were not crying about it, but you were just like saying that this is something that like affects your day-to-day life, potentially more than anything else.
Well, I didn't know you that well then, so I wouldn't cry in front of you then. But now, just hang on.
But I think the point there is it's very common. It's hard to focus on anything when you're in pain or you have reduced mobility. I mean, these things can really affect people.
The bottom line is it affects your activity of daily living. Buttoning your shirt, grabbing a pencil, putting on your bra. That we'll talk about that with frozen shoulder, putting your hands behind your back. And it affects you every single day. So that's probably why I said it. And I'm happy to say that most of my issues are now under pretty good control. I've had surgery, et cetera. So physical therapy.
We're gonna walk through all Steve's ailments on this podcast here. So let's start with the hands. So Steve, what are some things that people with diabetes in their hands need to be on the lookout for, or might affect them?
Well, the hands have several different conditions, and I think the first one we'll talk about. Ready for this, folks? Diabetic chiroarthropathy, and I think the name that we like better is the syndrome of limited joint mobility. And under that comes the stiff hand syndrome, and where people feel that when they make a fist, they feel like they can't even make a tight fist, or like their hands are somehow, they feel swollen because you can't squeeze them all the way, but they're not. And there's a positive prayer sign. I know everyone's going to be doing this right now. If you're driving in a car listening to us, be careful, unless you have a Tesla. You put your hands together like you're praying, and then you put your elbows up. In fact, for those of you listening, you remember this is also, we're videotaping this live. You put your elbows up and you get a little space in between your fingers. So if everything was normal, there should be no gap between your fingers. Right. You got to But when you get, this kind of limited mobility, that all of a sudden there's a gap between your hands. So push as hard as you can. No, lift your elbows up. So you're flat.
Yeah.
Yeah. And I mean, if you can see, I have this little space.
Yeah. The other thing that people can do is, first of all, people's knuckles can just get enlarged. Another maybe simpler thing is just putting your hand on a table, and you should be able to kind of, all your fingers should be able to kind of fully contact the table. And if you feel like things are, lifted up a little bit, it's a sign that you just have some reduced mobility there. And we don't really know why that is. The glucose itself is, it affects every part of our bodies. Is it getting into the connective tissue? Is it causing inflammation? Lots of research in this area. But if you're listening and thinking, gosh, that's me, I'm having some limited mobility, things like that. This is a time that you might bring it to attention of your doctor, maybe see a rheumatologist, who is a specialty that people don't know much about, but these are people that focus in these kinds of things and can maybe guide you on stretches, or, if things get, really severe, potentially surgery. But
silly putty,
because
that's something you can buy at Toys R Us. Oh, they closed. Sorry. But you can, it's very good to keep your hands, fingers moving. That helps. Yeah. And I'd say a good physical therapist is probably also an excellent choice. And a lot of times, just like our rheumatologist said, Ken, a lot of these conditions go in between physical therapy, orthopedics, rheumatology. There's an overlap.
And I would say, a good physical therapist is just worth their weight in gold.
Totally.
And the thing about a physical therapist is they're going to give you homework, no matter what the condition is, for your hands, your shoulder, whatever, the stretches, strengthening. And you got to do these things because it's so easy to go and just be like, I kind of want a quick fix. And now I got to go home and do these things 2-3 times a week. But if you do these things, generally, they work. Silly putty, racquetballs, whatever it is, things that kind of increase your mobility and your strength. So that's one thing. Okay. And you're thinking, all right, well, that's not the end of the world. Maybe I have some reduced mobility. Some other specific things that can happen in your hand, something called trigger finger. So what's that, Steve?
Well, we got to give the formal medical name, but it's, ready for this? Flexor tenosynovitis. And that's instructive because your tenosynovitis means you got inflammation of the tendons that move your finger. And what happens is, I love the way how I can describe how this is. It's like a fishing pole. The string that goes through the different rings is your tendon, your finger tendon. That when you push down, the tendon slides in between the different rings. But if your tendon gets enlarged, swollen, you make a fist and your finger gets stuck, and it hurts, and you have to undo it. So when it gets to that point, you got to do something. And it can happen in any finger.
And it's called, trigger fingers. Imagine using your finger to trigger a gun. As you pull the gun, it gets kind of stuck in that position where you can't straighten it. It gets kind of pulled back.
No violence on the show, please. But what's funny? I've had 3 trigger fingers operated on. It's super easy. And what they do is they just cut the ring that your tendon slides up and down. You don't really need all of them for your fingers to work. And I had one on this middle finger and this middle finger and this third finger. And my friend said that I used my middle finger too much, and that was punishment for doing that. But here's the therapy. First of all, don't wait, because the longer you wait, the harder it is to reverse. And a lot of times, either a hand orthopod or a sports orthopod will inject that area with steroids and reduce the inflammation. And if you go early, there's a possible chance you may not need to go to the next step, which is surgery. I tried injections of steroids all 3 times, and they did not work.
Yeah.
And so they take you in, and they did a beer block, not BEER, but I love that name.
Some guy named Johnny Beer,
Yeah,
something like that.
I don't know his first name. But what they do is they put a tourniquet on the bottom of your arm, and they infuse anesthetics so that the minute the surgery is over, you can drive home.
So you're awake the whole time.
Totally.
Just
Yeah. And I had the anesthesiologist take a picture, and that's the picture in the book. All of you should know that the TCOID book, although it's getting a little out to date, many chapters are not out to date. And we're happy to send you a free copy or the QR code where you can download it to your computer. So it takes about 15 minutes. And they put steri strips on, and that's it. And the problem is solved. And you can see here in the camera, but if you're not watching, my fingers are straight up and down. Before then, they would sit a little bit bent. And talk about disruption of your daily activities. Mm-hmm. And it's really worse in the morning, because when you lay flat, typically your extremities get a little more swollen until you stand up. So we got a ton of comments on this. Yeah. One of them was, "Are you driving right after surgery?" Because I said this on the TCOID Live. Yeah, you can drive with one hand. You just push home on the Tesla app. So I shouldn't make fun of that, because one of these days I'm getting an accident.
Well, that's super helpful.
Yeah.
So yeah, and it starts pretty mild, a little clicking with your finger, these kinds of things. And
Right.
It's just, again, what we're really hoping for is to inform people a little bit of an aha moment of, hey, I had that, and I just thought I stubbed my finger in a door and it was going to go away. This is something that is very common and kind of unique to people with diabetes. So sticking with the hand.
Yep.
There's other stuff.
Okay, you guys ready for this? Dupuytren's contracture.
From Johnny Dupuytren.
Everyone's first name is Johnny, especially little Johnny. Well, this is basically, it's persistent thickening and fibrosis of the tissues of your palm. Now, all of us in medicine know this because alcoholics get Dupuytren's contractures. And that's probably the worst thing about getting it, is that, if your doctor doesn't know you well, he thinks you're an alcoholic. But once again, it happens with people who have had diabetes a long time, and maybe related to poor control in the past, but it's inflammation, fibrosis of the tissues of your palm, and it can get fibrosed.
Yeah. So, and it's I think always, right, your 4th and 5th digit, meaning your pinky and your ring finger.
Yep.
And the tendons that go kind of from the base of your finger through your palm just get really thick. And they can be, so it limits your flexibility, all of that. So it's like trigger finger, but it just kind of affects a different area. The trigger finger is actually in your finger. You can't move the finger. Dupuytren's contracture is your palm becomes really kind of fibrotic.
The Dupuytren's doesn't hurt.
Yeah.
It's just, something you notice. Now, I'll tell you what, if it gets bad, you get a thing called the claw hand. It's like on horror movies or something. And I know a good friend of mine ignored it for years. And basically, when he shook people's hand, it was very uncomfortable for the person shaking his hand, because it was like a claw. Mm-hmm. He just could not straighten out. There's no flexibility. He went to a really good hand surgeon at UCSD, Reed Abrams, and it was an extensive surgery, and he's still not normal. He never will be, but he's 80% better. Mm-hmm. So don't wait. And you know what? Who knows why he was affected worse than others. But I think that's true with all of the conditions we're talking about.
Yeah.
Have you ever had a trigger finger?
I haven't.
Because you describe it perfectly. So
Yeah.
you sure you just haven't told me?
Well, I haven't had Dupuytren's contraction. I was waiting for you to make the joke about me being, somebody with diabetes and an alcoholic, which is a 1-2 punch for me. So it's a matter of time. But
Yeah.
the treatment is the same. Can they start with injections, Steve, for Dupuytren's, or they just go right to surgery?
I think they pretty much go to, if it's really early, physical therapy to reduce the fibrosis and inflammation. But I think they're going to need surgery if it really gives you the beginning of a claw hand, because it just gets worse over time.
Yeah.
I wouldn't even know where they would inject except all over your whole hand. So it's a good question. But I think with the trigger finger, they'll always do the conservative thing first.
Now, other things in the hand, again, this isn't, unique to diabetes, but we have carpal tunnel syndrome here, which can be more common in people with diabetes. And that can cause numbness in usually your thumb, your kind of index finger, and your middle finger. So the first 3 fingers. So you can see that we're focusing on different areas. That it's kind of funny that carpal tunnel is the first 3, Dupuytren's is the other 2.
Yeah,
So
yeah.
something's going to affect something, and that is usually numbness, tingling, and it's again through inflammation of the tendons now going through your wrist. So that's something that if you're having any kind of numbness there, they can do a surgery to kind of basically clip that tendon, allow more space in that tunnel. That it literally is a tunnel through the bones in your wrist. So it's not big enough.
Yeah, it's the same thing as trigger finger, except this is impinging on a nerve that's causing the numbness. And you're right, it occurs in up to 20% of people with diabetes. We commonly cause it an injury that you get from work, because you might be bending your finger, typing in a certain position. No, they got splints, they got physical therapy, they got injections and surgery, which really fixes the problem.
Yeah. And it also is common in people with low thyroid, which is also something that happens in people with diabetes. So
Really?
if you have carpal tunnel, that's something that might check your thyroid function too. So,
Well, could you mention that? Because low thyroid, you could have a condition called Hashimoto's, which is an autoimmune condition commonly associated with diabetes. And now we use that as a indication to screen for the autoantibodies. Might as well squeeze that in here.
yeah, we'll just add it to the list of stuff that we're subjected to.
Yeah.
Low thyroid and everything can fall apart in your hand and everything. So anyways, but the good news is these things, once they're identified, treatable, surgeons will tell you a chance to cut is a chance to cure. And in these situations, it's really true that you can, alleviate this pain, bring back your motion, flexibility, all those kinds of things. So, all right, the poor hand, let's leave it alone. And let's move up the arm to the shoulder, Steve. And this is something else that I know you've dealt with a lot. I will give the kind of lay term, frozen shoulder, and you've been so good about the medical term. So what's that called?
Adhesive capsulitis. And it's very descriptive. Adhesions in your shoulder that there is some inflammation, fibrosis that affect the tissues around the ball joint of your shoulder, preventing proper motion and flexibility. So it is one of the most painful things I've ever gone through. Anybody that's ever had one could empathize with me. And it's quite interesting that...
So can I ask, when you say it was painful, would it be painful just sitting here, or if it was just when you tried to move a certain way?
Yeah, when you try to move a certain way. Yeah, I could. It's also called frozen shoulder, or could it be frozen body for no pain? No, that's a great question. Addressing it with a physical therapist is painful. And I've never used this phrase better than no pain, no gain when it relates to physical therapy of adhesive capsulitis. Eric, our ultimate producer, director, videographer, and podcast chief, went with me to Dr. Jensen's office, Reese Jensen. If you live in San Diego, he's the man to see. And he got me through my frozen shoulder. Now, what's interesting is...
Well, can I back up?
Yeah.
And just say, there's lots of causes of shoulder pain and, decreased mobility and things like that. How did you know this was frozen shoulder? Did you get it? Did you need an x-ray? How can people diagnose this?
Yeah, well, I didn't know. And it started off just a little bit of soreness, like I had played softball and I swung too hard. And then it got worse and worse. And then, for example, if I went to put my hand through the sleeve of a dress shirt and then you put your other arm behind to find the sleeve, I couldn't do it. And so I was getting limitation of motion. So that's when I went to see Dr. Jensen, and he told me I had a frozen shoulder. Now, I waited too long because it started to develop during COVID. So I just assumed all medical offices were closed. They were open. And by the time I got to him, it was a little past the point of him being able to reverse it. I went through some pretty painful sessions where he has to sort of move your arm enough to break up the adhesions. You can't do that yourself. So even though I looked up online exercises for frozen shoulder, I did them, but you don't really progress, to be honest with you. And you're not going to push yourself to the point of extreme pain. Also, he grabbed my arm, like my arm is like a telephone pole, and he moved it in certain directions. And oh my God, so painful. Before I tell you how I got fixed, is that when you read about frozen shoulder, and he told me this, that I had one in my left shoulder 10 years prior. And I grinned and bared it. I didn't even go to physical therapy. And after 2 years of suffering, it went away. And if you read about it, it does say it has a limiting course. So if you don't see someone, eventually it's going to go away, but that's a long time to suffer. So we said, okay, we got to go to the next step. I went to an orthopedic surgeon who injected a numbing medication as well as a anesthetic. Well, it's the same thing. Sorry. And an anti-inflammatory.
Lidocaine, basically. So numbed you up.
And gave me steroids in the shoulder.
Okay.
So I went to his office in 1 hour, and Eric, you weren't there to film that, thank God. You'd probably still have PTSD. So he says, "You ready?" I go, "Yeah." And he takes my arm.
So wait, to be clear, you went to the orthopedic surgeon. They numbed you up with this injection. You went from that office to your physical therapist thinking, I'm numbed up, do your worst. Reese, I can handle it.
Yep. He didn't even tell me how bad it was going to be, to be honest. But he took my arm and shoulder and he yanked it. And I heard a very loud rip and tear. And he goes, awesome. And I'll tell you what, Jeremy, he told me I turned white as a ghost and I almost passed out from the pain. Now, how long did that pain last? It went away the minute he stopped. And 5 minutes later, the pain was gone and I was able to move my shoulder. So then we continued regular physical therapy to get the last remaining percentage. And so there are other things you can do. You can go into the operating room. They can give you anesthesia. He has sometimes gone and did
basically do what you did, but knock you out for
right.
it. Yeah.
And then really crank your arm around.
Yeah.
And he also told me if it happens in one side, if you get it again, it'll happen on the other, but you never get it twice in the same shoulder. That seems weird to me. Like, why? But I've never heard of anybody getting it twice in the same shoulder. So I'm done. Yeah. I did my left. I did my right. I'm ready to.
And now, how would you describe your mobility?
I'd say 95%.
And you can do everything you need to do.
Yeah. You know, the other day I was at the gym and I got on the pull-up bar and I just hung. And I was very sore for about 3 or 4 days afterwards. And I realized I got the last few adhesions, but that was nothing. So talk about ruining your life and your emotion. If I was a female, there's no way I could put on a bra with the opening in the back. Mm-hmm. I'd have to spend a ton of money and get the kind of bras that open up in front, like my girlfriend. Hope she doesn't hear this podcast. She doesn't listen to all of them. But no, it's a serious issue. You can't even get dressed.
Yeah.
And then
well, like I said in the beginning, like everybody knows these we got to look out for your kidneys and your eyes, and you get your eyes checked every year, and you do your urine every year. There's probably so many people listening that like, I've had this ongoing shoulder pain for so long, and it never even occurred to me that this was something that I need to be like on the lookout for diabetes. So I think your experience is, really powerful and helpful to people.
Yeah, it's also important to know that other people can get frozen shoulder. Women get it more than men, but there's definite correlation between duration of diabetes and glucose control. Because the glucose, as I mentioned in the very beginning, it does bind to tendons and ligaments in your body when it's circulating in excess. And that gives you the stiff hands. It might start some inflammation on certain joints. So, and I would say anecdotally, Jeremy, I find that this definitely occurs in old timers who have had diabetes a long time, from the olden days where the control maybe wasn't that good.
Well, I think another way of saying that is that it's becoming less common. That it's not just that you had diabetes for a longer time. It's that, when you were first diagnosed, your A1C was probably 10, 11. There was no A1C test. There was no, ability to keep your blood sugars under control. So it's not just that if you have diabetes for a long time, you're eventually going to get it.
Urine testing. Come on, don't forget that.
Yeah, exactly. It's that you and a lot of people listening have had it for a long time. And just because the care was so poor back then, you couldn't control your blood. It wasn't even recommended to control your blood sugars.
You're right.
You were doing what you were told, and how now here we are. So there's somebody, people listening that are like, gosh, I was just diagnosed. Is this what I just have waiting for me at the end of the like when I'm older? No, that, it's not a given that you will get these things. It's just, we're seeing it less and less now because of the care has improved so much.
I think that's well said. I think I totally agree with you. Should we finish up with the foot?
Yeah, the feet. Let's not forget about the feet.
I think we got one more major thing to talk about.
Okay.
You ready for this? Charcot joint.
Okay.
Now you pronounce the
we did
name.
it backwards. That was the lay term, and that one's kind of weird even in of itself. Diabetic osteoarthropathy.
Yeah. Okay. Well, I can summarize this because
and this is something we just don't see anymore, or very uncommon.
Are you a podiatrist?
I am.
Well, we see it less often, but here's the thing. Everyone needs proper nerve sensation to the muscles of their lower extremity. So when you develop peripheral neuropathy, where you really lose sensation in both your feet, and we know that's definitely correlated to duration of diabetes, history of poor control. When you get to the point where it affects your proprioception, so you might walk with a wide base gait, and what happens is it puts abnormal pressures and stresses on the ankle joint and the feet. So when you walk funny, these joints and ligaments aren't used to the way the weight is distributed. So what happens is you get breakdown, bony destruction of the bones of the foot and ankle. And because there's no pain, it doesn't really bother people because they're insensate. Now, if you had a picture of it, and you can see it in the book and online, the book looks like a club foot. And it's kind of big and round because the bony architecture of the foot is pushing abnormally from the inside out. And then those are abnormal pressure points, and you get ulcers.
Yeah. And you can lose kind of the normal anatomical structure of the foot. Your arch can collapse. Like when you say, how would you describe, what is a club foot?
Well, you know that guy that, I can't remember his name, but he played professional football, and he was a kicker. Who am I thinking of?
The guy that didn't have any toes?
Yeah.
I think he had like the record for the longest field goal.
Yeah. He didn't have half a foot, and he's got, he's a great field goal kicker. I don't even remember his name, but a club foot, when you look at it, looks like a club, and it looks like it's swollen, and it might be even, but there's big abnormal bulges. Mm-hmm. And as you know, my ex-wife Ingrid was a podiatrist that specialized in diabetic foot issues, and so I heard about these, saw these. She spoke at our conferences about them, and then when they cause an ulcer, it's really hard to heal. Mm-hmm. And you basically have to see an orthopedist, a good podiatrist that has done surgery on it. You have to get these extra depth molded shoes like the kicker, and it looks like, and it does display it spreads out the pressure so you don't have one point. And it's a tough condition. Common leads to amputation.
Sometimes I'll get asked, people say, I have diabetes. Am I supposed to see a podiatrist every year? What do you say to that?
I'd say this. If you don't have any feet problems, no. But if you are numb, that's what I tell people. I hate rote suggestions. Check your feet every day. If you step on a pin or a pebble and you scream bloody murder, that's good.
Yeah, you have sensation.
Yeah, you have sensation. And if you step on a tack and you don't know about it, that's super dangerous.
That's why I just leave tacks around in your office every once in a while.
Well, I can still feel them, my friend. Yeah. So there's a whole bunch more to people with peripheral neuropathy. They're prone to stepping on a nail in my office, or a tack. So that's it. It's immobilization, it's casting, it's proper shoes, and that's when you really need to be seen quite frequently.
Yeah.
And you're right. We're seeing it less and less. 1 in every 700 people is the latest statistic I looked up.
Oh, nice. Way to go. Well, I would say that kind of sums it up. And, those are definitely the heavy hitters. And no matter what condition you have, early detection, going to seek, a therapy, investing in the time for a physical therapist. And like I said in the beginning, that these things take work. There's going to be, you're actually always harping on me that I need to stretch more, whether it's yoga or actually just, stretching or whatever, just increasing your mobility, adding that into your daily routine if you can. Keep moving, exercise in general, I think I'm sure there's studies to support this. So helpful in terms of increasing your mobility throughout your life. It doesn't mean you have to, run a marathon, but if you're going to cycle every once in a while or walk or just, it really is a use it or lose it situation, I think. But again, these things are largely treatable. And you just mentioned all the things that you've gone through, but you're sitting here happy. You got all your fingers are straight and your shoulders, you just did a little, shoulders above the head. So that's fantastic.
Yeah. And if you notice, none of these conditions are treatable with medications.
Yeah.
It's kind of interesting, it's basically what you said. And I harp on you because I did not do that when I was your age. And I am daily stretching, not spending half my day stretching, but just even standing in a shower and moving my elbows from around both ways. And I do walk and I ride a bike. So I do get the joints going. And I think that's important for everybody.
Yeah.
You talk to some women, they do the yoga, Pilates, and they stretch all the time.
Yeah.
And then you talk to other people and they say, I don't really stretch.
Yeah,
so
it doesn't need to be a formal class. You don't have to put on
Right.
spandex. You're right. In the shower, work it into your daily routine.
I like wearing spandex.
Yeah, I know. I get the pictures.
Chula Vista Boulevard.
So thank
alcohol.
you everybody for listening, and make sure to like, follow, subscribe, share, love, whatever you need to do to get the word out. This has been a great podcast, and I think one that will be particularly ear-opening for people that might be kind of going through these different conditions. So thanks, Steve, for taking us down, your journey, and sharing everything with us.
Well, thank you very much, my friend. I happy to help anybody listening.
Yeah. All right, everybody. Take care.